Good afternoon. Thanks for coming to this presentation today. I look at this photograph and I remember that I had a full head of hair when I started working in addiction. I came here from Vermont. There's a not so nice Vermont and a very nice Vermont, but I'm not afraid of the snow anymore. I'm happy to be here. I started my treatment of addiction back in 2001. I went to work for a freestanding psychiatric and addiction hospital, and the CEO explained to me that I had to be medical director of 2 methadone clinics. I wanted nothing to do with that. I was afraid of addiction. I had no background. I explained it to him, but I needed the money, so I took the job. But about 6 months later, I realized that of the 700 patients I was treating, the majority of them were in a better place, back with family, back on the job, and doing well. So I spent the next 8 years or so working in addiction in methadone clinics. Then went to work in Worcester at a freestanding detox hospital. And I was seeing patients coming back constantly, over and over again, month after month, the same patient. And I began to research Suboxone. And I made the comment one day to a patient, I think you should consider Suboxone. It may break this cycle. The counselor with me took me aside and said, you can't say that here. We're a 12-step program. We don't believe in Suboxone. It's trading one drug for another. But I kept saying it, and about 2 years later, they opened their own program in Suboxone. Maple syrup is not the only thing that Vermont is famous for. Oh, these are the topics I want to discuss this afternoon. The definition of dependence versus addiction. There's a very clear distinction there. A patient who's stable on opiates is not necessarily addicted. We'll talk about that. The Vermont experience with opioid dependence epidemic, treatment options and outcomes for completing referrals, and what do I see in the Willamette Valley over the next few years. Dependence versus addiction. Dependence is defined by DSM-5 as a physiological adaptation that occurs when medications acting on the CNS are ingested with rebound when medications are abruptly discontinued. That's dependence. Addiction always involves aberrant behavior, including compulsion, uncontrolled use, drug-seeking behavior despite harmful effects. So you have a patient on an opiate for chronic pain. There's no aberrant behavior. Is that addiction? No, it's dependence. I like this slide. I think it best describes what our patients go through. At first, addiction is maintained by pleasure, but the intensity of this pleasure gradually diminishes, and the addiction is then maintained by the avoidance of pain. Our patients don't get high anymore. What they get is feeling normal and trying to avoid withdrawal. An overview, we've had some epidemiologic discussion already today, but this is something very brief. 10% of Americans age 12 and up are addicted to alcohol or drugs. It's 22 million people. That truly is an epidemic. New England Journal of Medicine defines opioid addiction as an acquired disease of the brain. It looks like probably 40% of addiction is nature. I don't know that we're creating addicts. I think we're aiding and abetting addicts. I think you're born an addict. But under certain circumstances, addiction manifests itself. Last year in Oregon, 908,000 individuals received at least one prescription for opiates, and 400,000 people were treated with long-term opioid medications. In 2016, overdose deaths from opiates have surpassed deaths from motor vehicle accidents. Ask your doctor if oxycodone is good for you. Side effects include empty pockets, theft, lying, withdrawal, nosebleeds, fits of rage, depression, uncontrollable itching and sniffling, prostitution, jail time, heroin use, and loss of friends. You don't see this commercial on TV. History of MAT in Vermont. Vermont opened their first methadone clinic in 2002, and there were 100 slots. Buprenorphine was approved for office-based treatment in 2003, and Vermont quickly adopted buprenorphine and became #1 state in the U.S. for waivered MDs and DOs, for doses per capita as well. There's obviously a difference between the two states, although I think Oregon and Vermont are sister states in lots of ways, especially their response to burning. There are only 600,000 people live in Vermont. There are more cows than people, so there's a difference in scale as well. But I think there's a lot to be learned from their experience. The Hub and Spoke program was developed by Governor Peter Shumlin. He spent his entire State of the State address in 2013 discussing the issue of opioid dependence, and the Hub and Spoke was the response. They designated methadone programs as hubs. Those were hub programs that were centralized and throughout the state of Vermont. There were 5 methadone clinics in Vermont at the time. And the plan was to open hubs in regions all over the state by the end of 2014. This is a slide of the sign right above my office. I couldn't believe that Kelly Story found this slide. She has amazing skills. Hub services. Buprenorphine could be prescribed just like methadone. So patients were given a choice between buprenorphine and methadone. Buprenorphine was prescribed every day, but there was some flexibility. Buprenorphine is a long-acting drug, has a 36-hour half-life. You can dose buprenorphine every other day, and that was done for patients who lived some distance from the clinic. They introduced the use of metal wheels for securing take-homes. Metal wheels are an electronic device you can load and lock, and it will deliver 1 dose of medication per day. And so it was meant as a device for avoiding diversion. Prior authorization, patients were required to fully dissolve and absorb sublingually the forms of buprenorphine, either film or tablets. There's much concern about diversion. And patients would sometimes take the buprenorphine out of their mouth, put it in their pocket, and sell it later on. So diversion is a big issue, and so they were required to stay in the clinic until their medicine was absorbed. Prior authorization process put in place by Medicaid for monobuprenorphine and doses above 16. The hub process, patients would call early in the morning for a same-day intake, so they would be seen the same day. Within a business week, they reported for the intake, history, and physical. They were to stop the opiates for a designated period of time and then go through induction. That designated period of time is because of the high affinity of buprenorphine for mu receptors. So if a patient's using heroin and uses buprenorphine shortly after, it'll kick him into precipitous withdrawal. It's a horrible experience. It's similar to Narcan, and so you have to avoid use of opiates for a period of time. For short-acting opiates, it would be 8 to 12 hours like heroin or oxycodone, but longer-acting like MS-Contin could be 24 hours. Methadone, at least 72 hours. So there has to be this break between using and starting buprenorphine. Hub services, intake, physical exams, screening for STDs, TB, HIV, hepatitis, education and referral, on-site urine screening and breathalyzer. Alcohol is a major problem. We did not allow either alcohol or marijuana in the program. We would work with patients on both of those over a period of time and not discharge them, but work with them. It may take months for them to stop using marijuana, but it was an abstinence program. Pregnancy screening and birth control information was provided at the hub. And the hub process is daily dosing of Suboxone. So patients came in every day, dosed at the clinic, went to groups every week. Level of care was decided by their counselor, so they might also have an IOP, intensive outpatient program as well at the same time. Callbacks were done. Patients called in the morning and given 24 hours to come to the clinic with their films for a count and a urine drug screen. These were very revealing. Suboxone films have a serial number. And so if a patient traded their Suboxone with someone else and then had it returned, you'd see it in the serial number. And so the callbacks were very revealing. Outcomes. 75% of the patients had comorbidity that I was treating at the retreat. And remember, it's a psychiatric hospital, and so Diagnosis were PTSD, bipolar disorder, major depression, borderline personality. About 50% retention at 6 months. That's pretty much a national number. So half the patients are still there at 6 months. Many patients stopped early on, started the program, didn't come back. That was a frequent thing. But eventually did come back. And so over time, you are treating these patients. 20% achieve take-homes, often after 1 year. Take-homes means you can get a week's supply at a time. So after 1 month of treatment, you're doing well, your urines are drug-free, you're going to group, you can take home medication for a week at a time. I was surprised that many patients declined take-homes. They didn't feel comfortable taking a prescription home. And if they're not comfortable, I'm not comfortable. But many of them did achieve take-homes, but it took as long as a year. Roughly 75% of drug screens were drug-free after 6 months, and that includes marijuana. So an intense program like this definitely works. My most challenging patient, I can tell you what it was like to treat this guy. A 36-year-old male was admitted to the intensive adult psychiatric unit 6 times in 2014 for PTSD and schizoaffective disorder. He was homeless and using heroin and frequent use of cocaine. His psychiatrist called me to make the referral to the hub, and I was extremely skeptical. I said, this guy's not going to make it. I mean, how's he going to get there every day? We're not sure how this is going to go, but we did accept him. He had a very well-organized and hardworking counselor who got him intensive care for his psychiatric disorder, met with all the counselors, met with the emergency department. He was going to the ER once or twice a week with complaints. Over a period of 6 months, he got housing and a payee, and that was pretty important because his big trigger was getting money. The first of the month, he was always paused for cocaine because that's when his check came in. The payee would give him $10 for lunch and some money for cigarettes, but not enough for cocaine. And so he did reasonably well. In the last 6 months that I worked with him, he was drug-free except for marijuana 1 time and had not been hospitalized in over a year. And so these programs work even with the most challenging patients. SBIRT, you do your screening, and then what? There are multiple options for opiate dependence. Inpatient detox, patients often see as a cure. They would like to go in the hospital as if they had pneumonia and come out entirely well. That would be like a diabetic with DKA coming out non-diabetic. It doesn't work that way. But for patients, the feeling is, I'll go in the hospital, I'll pay my dues, and I'll no longer have to deal with addiction. It doesn't work that way. Inpatient detox is a 3 to 5 day using either methadone, buprenorphine, or sometimes clonidine. In a study in 2001, there were 116 patients that went through a 3-day detox and followed at 1, 3, and 6 months. There was a 70% relapse in 30 days. And so, again, this is not a cure, it's a beginning, it's the start. 11% were negative for opioids and cocaine at 1 month, 13% at 3 months, and 12% at 6 months. Inpatient detox is acute care. It's very much like DKA for diabetes. These are pretty sick people. They're overdosing, they're at risk of death, they're homeless, they're out in the elements. And so inpatient detox is still there and is still being used. Residential. The most studied population are emerging adults age 18 to 25. And from 98 to 2008, prescription opioid dependence increased by 350% in this population. Study in 2014 of 219 patients after a 30-day residential program that included motivational enhancement, cognitive behavioral therapy, and family-based therapy. At 12 months, 29% were drug-free, including some of those who had discontinued MAT. This is a hard population to treat in MAT. The retention rate at 6 months is only 17%. And so residential makes sense, followed by other kinds of treatments. We'll talk about that as well. Medication-assisted treatment. Buprenorphine prescribing alone does not constitute a recovery program. I think that our colleague from SAMHSA made that comment as well. I like to call it medication-assisted recovery, which emphasizes the need for treatment, including therapy and substance abuse counseling. Outcomes for buprenorphine treatment. Study in 2009, 121 patients in a Baltimore primary care setting. After 12 months, 56% were remaining in the program. 64% of their months were opioid negative for drug screens. 47% were opioid negative at 6 months. And that's a pretty common figure throughout the country. Methadone maintenance therapy. I won't go into a lot about MMT. It started in 1964 in New York City to reduce crime. It was actually a favor of Richard Nixon. The outcomes are similar to buprenorphine, except retention is considerably higher in methadone. I've never understood that. Methadone is a much more intense program. There's more structure. You're required to dose every day for at least 3 months, and then you're given one take-home. So you can contrast with Suboxone, where you can be given a weekly prescription. So it's much more structured. Although buprenorphine treatment is more popular, there's still a role for methadone. Methadone is much more structured. And the concern for diversion is much less because methadone's a liquid. You swallow it and leave the dosing window. You have to talk to the nurse to prove you're not cheeking your methadone. And it's much easier to deliver than Suboxone, which requires melting. We've talked about agonist therapy with buprenorphine and methadone, but there's also antagonist therapy with naltrexone. Naltrexone is an opioid antagonist at the mu receptor. The disadvantages are to avoid precipitous withdrawal, you have to be off of opiates for a long period of time, 48 hours or more for short-acting opiates, and as long as a week for methadone. So you have to get through that period of time before starting naltrexone. It's also very painful at the injection site. Naltrexone is a very thick, viscous liquid, and the injection hurts. And so there's some problems with compliance because of that. But compliance is much better than by mouth because a monthly injection's over, it's done. Patients report reduction in cravings after 1 week. There's a lot of interest in using naltrexone in jail, in prison, giving the first injection there and then injecting the patient afterwards as outpatients. I think there's more to come on that. The main advantage is you can't divert naltrexone. It's an injection, it's over, it's done for the month. You can't sell it, you can't divert the medication. So compliance is much better. Outcomes with naltrexone. In 2016, did a study of 308 patients. They received monthly injections of naltrexone. Relapse was defined as 10 days out of 28 days. So relapse was not a one-time thing, but using 10 days out of 28. There were no overdoses seen in the study, and 43% relapse rate in the study group versus 64% in the control group. I think that the concern I have with naltrexone is cost. It's $1,300 per injection. Insurance does cover it, but cost is a major problem. We talked about pharmaceutical costs before. Vision for the Valley, a much needed residential program in Lebanon. There is right now a delay of up to 3 to 6 months trying to find residential treatment, and certainly there's a need. What do I see in the Valley? Your SBIRT is done. There's a need for opioid treatment. There's a diagnosis made. Where do you go? Assessment and intake, residential, IOP, or outpatient, or all three. Not everybody needs to be on Suboxone. And for a new user, I think the route to take is residential and then outpatient treatment. And so Suboxone or methadone is not necessary for everybody, but certainly the chronic users do better. If we're looking at MAT, I would like to do intensive MAT first. treating patients 3 to 5 times a week, trying to avoid diversion, and then going to weekly and then biweekly, and then back to the PCP. This could take 3 to 6 months, but my concern is early on, diversion is a major problem and compliance is a major problem. And so what I see here, I think the experience in Vermont could apply to Oregon. I think that if you're out there in primary care and your plan is to prescribe Suboxone, you need to know what your alternatives are. What other treatments, what level of care is most appropriate for that patient? In the hub program in Vermont, we frequently had patients leave our hub program, go out to the community, get treatment out there. Something happens, they're not doing as well, they start using again, they go back in the hub and then return to the outpatient program afterwards. I think with careful practices and procedures, this can be a gratifying part of your practice. Not every patient is difficult. I painted a kind of difficult picture here this afternoon, but these are the most intense patients. There are lots of patients who can be prescribed Suboxone, return on a weekly basis. They're compliant, they're grateful, and they're not difficult patients to treat. When they are difficult, send them to me. So your medicine fell down the sink by accident. It was just your pain pills, not your blood pressure pills. Yes, we're going to see things like that. What is it about coffee in Oregon? In the East, there's Dunkin' Donuts and Starbucks. There's a coffee shop on every corner in Oregon, but I must admit it's very good coffee. Any questions?